Good evening to one and all. I would like to introduce to you our speaker, madam, for today, Mrs. Namagiri Lakshmi. Uh, she is currently working as an occupational therapist for the Alberta Health Services at the Wainwright Health Centre in Canada, where she works with adults and geriatric clients with various neurological conditions. She has expertise in the functional assessment and rehabilitation for ADL, transfer assessment, cognitive screening and remediation, creating adaptations and modification for ADL independence in hand rehabilitation, upper limb splinting, and seating position assessment. It is our delight to have you amongst us, madam, and I invite you to share your experiences with us and to interact with our students. Thank you.
Thank you, Rima. First of all, I want to check whether my mic is working. Do you guys hear me well? Is there echo? Is there any problem?
We can hear you, madam.
Perfect. Thank you so much. This is a good morning from me, but I know you guys have sacrificed your Sunday night. Thank you for joining. I should thank Dr. Raghuram sir because he gave me this opportunity to share my experiences. I'm not going to be giving a big webinar or a big presentation, but it's just more of an interactive session where I can share my experiences in Canada. So first of all, guys, I just want to know whether you all are like in first year or second year, or like everyone, is it a big group of different year students?
All the batches are present, madam, from first year to the final years.
Oh, perfect. Thank you, Rima. Thanks for answering that question. So as Rima told, I'm a registered, regulated professional. I'm an occupational therapist at Alberta Health Services in Wainwright Health Centre. It's a 22-bed unit. It's an acute care 22-bed and a 65 long-term care bed unit. And then there are outpatient rehab services that are offered too. So it's quite a busy day every day. It's quite a happy experience to be an occupational therapist because you get to meet different variety of population with variety of condition, and you are a creative therapist who can solve many problems that are unattended or not recognized as a problem at all by other professionals. So it's really proud to be an occupational therapist. You guys will eventually see that in your practice. My caseload in a day would range from like a 10 to 15 clients, mostly adults and geriatric. I just wanted to give you a short description of the Canadian healthcare system. Canadian healthcare system is funded by the federal government, so most of the cost of the healthcare expenses are covered by the government. Only thing is the vision and dental are privatized sector, but all the other things are covered by the government. So my job in a hospital is to serve patients and also make sure that they don't stay for a long time in the bed and taking up funding, which is not necessary. We do see that sometimes clients need to stay for a long time, but mostly it's like the length of stay in an acute care setting is a target for us. It's not like a productive target, but it's our goal to help people to go back to their function as early as possible. And that's why you are here. So all hospitals in Canada are basically, they have the whole multidisciplinary team, like a physician, a registered nurse, a licensed practical nurse, a nursing attendant, a healthcare aide, a dietitian, an occupational therapist, a physiotherapist, a speech language pathologist, a respiratory therapist, and a recreational therapist, and more people. Like, so most of the multidisciplinary team work is to help people go back to their original environment, back to their baseline. But if they cannot go back to their baseline, then we think about other services that we can arrange for the client when they go back to their home. My duties and responsibilities, as I told you, like functional assessment, transfer assessments, cognitive screening, dysphagia assessments, discharge planning, seating and positioning, and comprehensive lower limb assessment, and to manage edema, pressure ulcer management, upper extremity splinting, and hand rehab. So these are some areas which I practice. And basically, I'm a level 1 occupational therapist. There are more specializations in Canada, which you can go with more education and more expertise. Any questions for me? What do you expect from me? Will you be able to answer, Rima? Like, what would your students will be expecting? Okay. So when I had a chat with your HOD, Dr. Raghuram sir, he did mention that all my students are will be experiencing some anxiety about like how their practice would be. So I thought I would say like your practice is going to be wonderful. You all will be like be a wonderful, successful therapist when you put your theory into practice. So he did ask me to give a small uh, presentation, or maybe just sharing my experiences in each of these areas. So maybe we will start with one area today, which is the transfer assessments. Are you guys okay with that? I'm just going to put a PowerPoint presentation. Hopefully that will give you a little more information, and then you can review whatever you read in the textbook. Okay. Okay, I might have some difficulties. I'm going to take a couple of seconds to get connected. Hang on, please. Do you guys see my screen?
Yes, ma'am, we do.
Yes, ma'am.
Okay, so do you see a slide saying transfer assessment in everyday practice?
No, ma'am.
Okay, so that's the trouble. Okay, let me figure out on how to do this. Okay.
Derima ma'am, maybe you can help her ma'am.
Hello, madam. Can you see a present now option
Yeah,
below? When you
yeah.
click that, you get three options: a Chrome tab or a window.
Mm-hmm.
Uh,
Yeah,
so your slides are on the window or on the Chrome tab?
it's on the Chrome tab.
Okay. When you click on the Chrome tab, you get the options.
Uh, I am trying. Let's see. So, what do you see?
Yes. We can see your screen.
Okay, so maybe if I go into my slides, so is it possible to see the screen now?
Mm, It's blank for me.
Okay, okay, okay. Let me check what I can do from my side. Okay, sorry guys. Okay. Are you able to see my screen now?
Yes, yes, we can see.
Okay, perfect.
Yeah.
So transfer assessment in everyday practice. Whenever we say a transfer, we should know what is a transfer, why we are doing it, and how are we going to do it. So a transfer is a method of moving a patient from one surface to another where the patient is capable of helping with the transfer and is able to bear weight on at least one of his or her legs. So the main transfer as a OT, we are interested in like a chair transfer, a bed transfer, and a toilet transfer. Uh, why do we check transfers? Because being a multidisciplinary team member, we are concerned about the safety of a patient's current function or that the patient has a physical condition that may affect their transfers and mobility. As OTs, we check that the transfer is safe if they require any equipment to ensure a safe transfer. This is especially very important for a discharge planning because when we send people home, we need to make sure that they can do a safe transfer at home. This enables us to check that they have the most appropriate equipment at home to meet their needs. Okay. And how are we going to check the transfer? So initially, when I get an as a referral from the physician, it'll be a client so and so requires a transfer assessment or a rehab assessment. So I always go into a client's chart and see what was the client's baseline before. So they might have been independent, they might have been wheelchair bound, they might have been using an assistive device to ambulate. So we need to know what was their baseline. And then the medical history. So as you guys know, whether the client had like any falls, any balance issues, any head injury, stroke, or any medical history like hypertension, diabetes, anything that is related to the client that can affect the client's physical strength and mobility. And what was the recent diagnosis? Like, why did they come to the hospital? So that's very important too, because we don't want to move a patient who is really dizzy or having some heart condition or having a DVT, which is a deep vein thrombosis. So we have to make sure like why the client is admitted in the hospital. So I also go through the recent physician notes and nurses notes just to see whether their pulse and heart rate and their medications, because sometimes some medications can relate to falls and some medications like anti-epilepsy medications can make people so fatigued. So we need to know what is going on with the client. Okay. And what are the transfer orders? So sometimes the patient might have been coming from a different hospital. So we need to know what is the goal of them here and what are the precautions that has been indicated for the patient in the previous hospital. In Canada, we can see a lot of patients with hip fractures and knee fractures, mostly because we have a lot of snow. There can be ice and they can like fall in that black ice and they end up having a hip fracture, and they go to a special hospital to get a surgery, like a hip replacement surgery sometimes, or a arthroplasty surgery, like a correction of fracture. So we need to know what is happening with the client and whether they can put weight on their limb or whether they are not allowed to put weight, whether they are partial weight bearing, whether they are toe touch weight bearing, or whether they are full weight bearing. So we need to know the status of the client before we start a transfer assessment. So when I go into a client's room, I greet myself and then I introduce and then I tell what is the purpose of I am being there, and then what is my role in their care. So it's a good way to build a rapport, and then you can also evaluate at the same time whether the client is able to hear you well. Sometimes older people, they can't hear you, and when the instructions are given, they're just dumb, and you might think they're not having information processing. So we just need to start with the basic hearing assessment. So whether they can hear you, whether they are cooperative, whether they are alert, if they are dizzy, if they are like not able to follow direction. So all these can be identified when you are doing the initial assessment. So start a rapport build, and then actively listen to their complaints and actively listen to their stories, because they can tell you a lot than what we can see. So always start with this step, and then we always check for the grip strength in their hand and the range of motion. So ask the client, may I hold your right or left hand? So, and have this client squeeze your hands to determine the grip strength. Ask the client to push laterally outwards, then pull inwards. So you are basically checking the abductors and adductors, and then push straight away from self and pull towards self to see if they are able to move their upper extremity close to you, and then whether they can like take their upper extremity close to them. So in a way, you are like functionally seeing whether their range of motion and muscle power is good enough to do the assessment. And when you see the client lying on their back, you can ask, can you bend knees and place feet on the bed surface? So that's the way you can see the range of motion in their knee and hip, and then see whether their ankles can be placed flat. So I do know we always talk about goniometers and like MMTs, but these are all very basic functional assessments. So it's like eyeball measurement. You just see and judge how much the client can do by themselves. So we are not doing a range of motion or a muscle strength assessment at this point in time. We are just seeing the functional assessment, whether the client can do this function in order to proceed with the transfer assessment. So instruct the client to raise their hips up off the bed. So this movement is called bridging, which you all very well know. See whether the client is able to do this position, can maintain this position, and see if there's any deficits in it. The client may require more than one attempt to perform this maneuver. You can provide minimal assistance to the client, such as verbal encouragement or guiding touch. You do not bear any of the client's limb weight. So you're not pushing the client's hip up, or you're not going to bear any weight. So so when we assess, we need to say what is their functional level. We are not treating them at this point of time. So we are just going to see what they can do by themselves. Ask the client to roll over to the side. So this observe the client's ability to roll over from side to side in bed. You may provide minimal assistance as needed, such as encouragement or guiding touch, but don't weight bear their limbs, like don't push them or don't pull them to the position. It is just a guiding touch. Position yourself on the side of the client where he's rolling, so you can observe and ensure safety of the client. The client may use side rails to assist in this movement. So basically in the hospital bed, you can see the side rails, and always make sure the side rails is up. So if they need help, they can hold on to it and they can turn. The next step is from supine to sitting at the edge of bed, which is also a very important step in the transfer assessment. So lower the bed to the correct height for the client. The feet should touch the ground. Have the client assume to the sideline position and instruct them to push with their arms as they swing their feet off the edge of the bed. So you need to watch what they are doing, whether they are able to bring their leg outside the edge of the bed. You may provide minimal assistance, such as raising their head or raising the head of the bed, or encouraging use of the side rail. So you can like provide minimal assistance by guiding their hand to touch the side rail so they can hang on to something to raise themselves up. So you must not bear the client's body or limb weight in this step 2. Stay close to the client, observe the client in a sitting position for 15 seconds. So some people, when they sit up, you all know there can be a change in their blood pressure. So there might be symptoms of dizziness, or they can like, if they don't have a trunk control with neurological problems, they can like have balance issues. So please be close to the client and see whether they are able to sit upright, whether they need some support. Some people like hold on to the side rail and sit. Some people push their hand on the bed and they try to sit up straight. So watch for all these steps, what the client does when they do this transfer. Knee extension. So once the client is in a seated position for 15 seconds, ask them to straighten one leg with the heel off the ground and hold for 3 seconds. So this way you can see their range of motion in their knee, their muscle power against gravity, and then to see if they are able to weight bear on the other leg when the other knee is off the ground. So you need to watch for all these steps. The client can perform this within their available range. If they have limitations such as contractures, arthritis, knee surgery, etc. And repeat on the opposite side to see the other knee flexion, knee extension, and ankle position. So the function we are addressing is knee extension, not hip flexion. So you're not going to lift beyond the necessary knee extension degree. Okay. So the next step is to try to do the sit-stand transfer. So the client is sitting at the edge of the bed, is able to do knee extension for 3 seconds, and they are willing to try to stand. So determines the client's ability to stand. Note the client's ability to position themselves in preparation for the move. See whether they are pushing through the bed to stand up. See whether they are holding on to the side rail to stand up. See whether they are pulling on something, or see whether they are asking for help by showing their hand. So you need to watch for each step. So you can help them like setting up the bed and then asking them to lean forward slightly. And you can also ask them to support their weight by keeping their foot flat on the ground, and then ask them to come to the edge of the bed. So you can ask them, can you scoot forward and sit at the edge of the bed? Client may use mobility aids such as walker or a cane or the side rail of the bed. So you allow them to do what they can. So you're not going to say, no, don't use the side rail. I want you to do a stand. Don't stop them, but just observe them what they are doing. Observe the client's ability to perform the to stand move. So sometimes some people need couple of rocking motion to stand up. Sometimes they need 2 times attempt, like a 2 attempt to stand up. So watch for all this, whatever is happening. And then maintaining standing position. So once the client is up, so see how much they can weight bear by themselves. Just be close to the client so you don't lose them. And before we usually do a standing, we always tell clients about putting a transfer belt on, because this belt is something which you put around their waist and you can hang on to it so that there's no pinching of skin, or if at all there is a fall, you're not going to hold the client's upper limb or like pinch the client's skin. So avoid that. Sometimes this can cause more injury than what is currently the client's medical diagnosis is. So try to use a transfer belt so that you can hang on to it when they are up and above. So see whether the client is cooperative, predictable, reliable in physical and mental performance. This is very important too. If the client is not predictable, then you are in trouble, because in the middle of the transfer, they can like sit down or they can reach for something, and it's definitely a hazard for yourself and for the client. If the client is not reliable in physical performance, then you need to ask for extra help. And if they are not cooperative, you're not going to do it by yourself, ask for help. And if the client's mental performance is not well enough, then a one-person assist can be a danger. So ask for help. Okay. So look for what assistance they are needing. So some clients may be a person who does not require any hands-on assistance. So they are categorized as an independent transfer person. And then a minimum assist transfer where you can just do a physical cueing or a verbal cueing, or even set up the equipment. So you can put the side rail of the bed up. You can put a walker in front of them. You can give them like a cane. So they just need some setup assistance, and then maybe a very minimal verbal or a physical cueing. The next level of assistance is one-person transfer with the belt. So belt is always there during the transfer. The worker must provide directional pressure or additional momentum to assist a client to participate in the moving technique. So the role of the worker is to just give an additional momentum, but not lifting or weight bearing the client's body weight. In Canada, it's very much standard that no lift policy. So we are not going to lift anyone. So why do we say this? Because as I told you, like in a day, I see 15 clients. So if I'm going to lift 15 patients in a day, so it's like in 5 days, 15 into 5, and then 30 days, 15 into 30, and then 15 into 365. So I'm repetitively straining myself, which is not a good standard, because the worker has to be safe and the patient has to be safe. So in Canada, no lift policy is very important. So we will see how much assistance we can offer. It can be a one-person assist, or it can be a two-person assist, or it can be the next levels. So so the next step, I would say there are like a couple of one-person assist transfers. One is one-person stand pivot transfer, which is the most common transfer you have seen already. So the step one is to guide the patient's upper body with your arm. You can have your arm under their, like on their waist, but not under their armpits, because sometimes when we snug them with the arm under armpit, we can cause shoulder dislocation, subluxation, or even a nerve injury. So we always hug them, or we always go around their waist. and then guide their lower limb. It can be one lower limb guidance for a stroke patient. If it is like one limb, then you just guide their weaker limb by giving a support, like you place your leg outwards, like laterally, to support that knee, which is not working for them. So always the transfer is recommended on the dominant side, so or the stronger side. So we always ask patient to lead with their stronger side and reach the surface and then reach the armrest. So if you see the step one, the therapist is helping them to raise up, and then that is the first step. And then rather than twisting, they do a pivot. So it will be like two different steps. First, raise up, and then take small step, and then turn, which is the pivot, and then help them descend down. So these four steps are very important. Twisting is most common injury. Many people make it like a fast pivot by twisting, but it's not worth it. You are injuring your back, and there might be chances that the client can like fall down and you won't have space to even adjust. So do it as a two-step movement, up, and then take a small pivot, like small step, and then the full pivot, and the client has to reach the armrest of the wheelchair and then descend down. Okay. And the next one person's transfer is a one person squat pivot transfer, where the client, basically the whole process is the same, but the client puts their upper body like on a lean position, like a half squat position, to help the momentum. So basically, both the transfers are the same, the process is the same, just the body positioning is different. So if you see the client is like bent over, and the therapist has a straight spine, and then the knees are bent, and the therapist's feet guides the client's feet during this process. Next common thing is a sliding board transfer, where a person uses a sliding board that is a bridge between one surface to the another surface. Most commonly, it's used by people who have a good upper body strength and upper body range of motion, and like upper extremity range of motion too. We usually tend to avoid this transfer because we have seen a lot of patients ending up having a skin breakdown by the shear force or the friction that causes when they are transferring in this process. So we try to avoid this, but sometimes there are many people who have a good upper body strength. They can push up themselves, and we can like do a smooth transition. So this is also used in some cases. The next level of transfer is the two-person assist transfer with a belt. So when you can do the one-person assist transfer, then if you need additional assistance, there are two workers to provide that additional momentum. As I told you, the client has to participate, and both of the workers have to participate. It's just the extra assistance. You are not going to manually lift or bear the client's body or limb weight. It's just an extra additional momentum. If you see this, you can see like one person is in the front and the other person guides the pelvis. So one person, like a one person assist transfer, you are in the front, same positioning, and the other person is behind, just helping with the pelvic position to come to the transferring surface. So these are the most used manual transfers. And if these transfers are harder, and if these transfers are not successful, then we go to a mechanical assistance transfer. So we use a manual lift, like a mechanical lift. It's a sit-stand lift or a total lift. So I can like show up pictures. It's coming. Always take into consideration the client's ability to stand and bear body weight through part or parts of their body. So you need to see whether the client is able to at least bear some weight on his legs, whether he can hold on to the handles, or whether he can participate by physically participate by putting some weight on the floor. So this is the sit-stand lift, which we use for patients when the two-person assist transfer is not possible. So if you see, this lift can be operated by one person, but we recommend two-person because one person has to operate and the other person has to guide the patient to the surface where they are going. So these are usually in all hospitals, in all assisted care facilities. There is also an extra pelvic positioning belt just for people who cannot do hip extension when they are moving. They don't want to like actually like it shouldn't be like a hammock where they are like hanging down, because hanging down can cause brachial plexus injury, because see, the sling is under the armpit, and if the client is not able to actively extend his hip or actively control his trunk, then they eventually can get injured. So we also see whether they have that amount of control. So if you see, the knee is positioned well and they are able to weight bear with their knees. So this one can be used for people who can like partially weight bear, can hold on to one armrest at least. Okay, so always good that the client is always checked for their alertness, their cooperativeness, and whether they are able to follow direction. If all the above is no, then the client requires a total lift where the client doesn't have to participate much, but they can just like hold on to the ceiling lift. So this is the higher lift which we use in the hospital. So if the client is not able to weight bear in any of the part of the body, their legs are not helping them, their hands are not helping them, then in that sense, we try to go for a higher lift. This is another higher lift, but it's a ceiling lift where the ceiling track has been installed and the lift is like connected to the ceiling. So it's the previous slide which I was talking about is just a lift that is on the ground level. It has parts that support a lift from the bed. It just lifts up the person, but this one is from the wall. It's installed on the wall. So if you see, like the hospital wall has ceiling lift for people like who are more heavier or who needs more assistance. So they go for a ceiling lift, like a bariatric person or obese, but still they're not bariatric. Like they're super big. So those are people who need like a 3-person, 4-person assistant, which is hard. So we go for a ceiling lift. Well, after assessing, you need to document. So documentation is very, very important in Canada. After completing the functional transfer assessment process, you have to determine what is the safest and most suitable transfer method for the client. I'm going to show the functional transfer record form, what we use every day. So we need to put the client's label on the top right corner. We need to sign and date at the bottom and assign a primary logo saying that this client is an independent transfer, a standby assist transfer, a 1-person assist transfer, a 2-person assist transfer, a sit-stand lift transfer, or a total transfer. Sometimes a secondary logo is required because In the morning time, after a good sleep, the client might participate more good, but in the evening, they might be more fatigued and they need maybe extra assistance. So a secondary logo is also placed if it is required. Once this is done, we will file the form on the patient's chart and we communicate the primary logo in a various places, like we display that laminated logo by client's bedside, write a note on their whiteboard, place a logo sticker on the client's wristband. So we try to communicate this to the whole team by doing this. So throughout the process, communication with the client is the key. As I told you, they will be able to tell you more than what you see. So remind yourself that while safe client handling activities are commonplace for you and you are familiar with the equipment and techniques, this likely is all new to your client. So you are well versed with all these transfers with the lift, but the client might be very new to this. So explain them and tell them that you are on a safe place with safe equipments. Before, during, and after a transfer, communicate openly and clearly with your client. Let them know what they can expect, how the use of safe techniques and equipment keeps both you and them safe, and how they can participate in this transfer to the best of their abilities. This approach will reduce the occurrence of unexpected events, reassure clients who may feel nervous or anxious, and result in safe client handling outcomes. So this is the functional transfer record I was talking about. So do you guys see this well? Like, hello?
No, no, ma'am.
So, okay,
Yeah.
hang on. Okay. Um, I'm just going to see if I can make it bigger by some means, but I don't know how. Hmm. Well, I'm thinking I'm running into some problem. Do you guys think you can help me out? Or maybe I should call someone to help me out?
Yashwant, Yashwant,
Yes, sir.
maybe you can guide her, okay? Or any of you volunteer, please direct her.
Ma'am, now we can able to see the screen, ma'am.
Oh, okay. Okay, hang on.
Maybe if you have the image, you can show us, ma'am. In that, you can zoom also.
Okay, I'll try that. This can be done now. Are you guys seeing my screen?
Yes, ma'am.
Okay. Do you see it now?
Yes, ma'am.
Okay, so this is the functional transfer record which I was talking about. So to minimize, to show you the full, and then I will like maximize it. Perfect. Okay, so I would better start like reading it. Do you guys see it well now?
Yes, ma'am. Yes, ma'am.
Okay, so the functional transfer record, like I always see there are boxes to check like whether it's a initial assessment or sorry, there's some problem with this. Okay, so whether it's an initial assessment or a reassessment, so you start and then gather initial client information. So the initial client information is fall risk management to see whether, excuse me. Okay, so to see if they have any risks, like whether they are like risk for falling, and then you also see mobilization precautions or contraindication. As I told you, there might be some transfer order saying that the client cannot weight bear or the client cannot do partial weight bearing, whether the client is a toe touch weight bearing or whether the client is totally non-weight bearing. So you need to know the mobilization precautions and contraindication. So the next step is to see their grip strength in their hands and arms, and then also their range of motion. Perfect. Okay, and see whether they are able to do the bridging, and then consider physical and mental performance. This is just the review of what we already saw. This is just an algorithm that explains what we already saw. Oh, sorry, guys. There was a problem before too in this laptop, so bear with us. Okay, so once you gather initial information, see whether the client can roll side to side. If no, then obtain assistance, then continue. If yes, then go for the next step, that is whether the client can coming up to sitting position and stay in sitting position for 15 seconds. So if the client can sit up for 15 seconds, then see whether they can do the knee extension and hold for 3 seconds. I'm sorry for this. Okay, and then if they cannot sit up, if it is a no, then go to the next step. Once the client can sit and straighten their leg, then the next step is to see if they can stand up. Oh my goodness. Okay. If the client can come to a standing position, oh my goodness, I'm really sorry for this. Okay, I'm hoping this will stay. Okay. Okay. If the client can come to standing position, just see if they can follow directions. If yes, okay, I'm hoping. Okay. So if the client can come to standing position, look whether they can follow direction. If they are able to follow direction, then see whether the client can bear body weight for 15 seconds. Okay, so this is the maximum. Okay. Okay. If the client is cooperative, predictable, and reliable, then try the next step. If not, as I told you, if they're not able to follow direction, if they are not able to partially weight bear, if they are not able to do some walking or shuffling, then go to the sit stand lift. If the client has a partial weight bearing ability, like some weight can go through their legs or hand, then you can really test the sit stand lift. If that is not possible, then go to a total lift. Do you guys see this now? Are you able to see?
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
Okay, so if you see the logos, it can say whether you are independent. So the first logo is saying that the person is independent, and the second logo says just needs supervision. The third logo says one person assist, and the fourth logo is two-person assist, and if not, the mechanical assistance, so a sit-stand lift or a total lift. Okay, back into the presentation. Do you guys understand this? Do you think you need more explanation on this? Can I proceed?
Yes,
Yes,
ma'am.
ma'am, you can proceed.
Okay. Okay. Do you guys see my screen?
Yes, ma'am.
Yes, ma'am. Yes, ma'am.
Okay. So some of the assistive devices is like the bed rail, which I was talking about. This is a M rail. It's shaped as a M, so that's why it's a M rail. So if the client needs the bed rail support, then we can always say when the client goes home, we can get a M rail from the government and give them for that independence. And if the client needs more support, then we go for a pole. So this is called a Saska pole. It is connected to the ceiling. So it's connected to the floor and to the ceiling. And then the client can use this to help to raise themselves. So there are other additional assistive devices like a overhead trapeze. So that is something to help people to weight shift and then help their upper body to position in the bed. And then this is a leg lifter, which we commonly use for geriatric population. Many people have trouble lifting their legs up, so we just tell them that this could be used to help with lifting their legs. So in the bathroom, we also see whether they are able to, like, it's almost similar to the transfer that they do in a chair, but you might have to see whether they are able to sit on a commode without any armrest support, or are they catching on to the counter or somewhere to help them descend down. You can also see whether they need a rail for support, that is like a horizontal rail or a vertical rail or a diagonal rail. So in the tub transfer, so Canada, most of the houses have tubs for bath. So we also see whether a tub transfer bench will be more beneficial for transfer to the tub. So many people cannot lift their leg and go inside the bathtub. So we make sure that we get a tub transfer bench so people can sit and slide themselves into this into the bathtub. So some of the assistive devices are like two-wheel walker and four-wheel walker, which we use it every day in practice. So when a person stands up and looks for some assistant to hold on, we give them a two-wheel walker. So that gives them a more stability and a good base of support when they are walking. And if they are super confident, if they are safe, and if they are showing good ambulation with two-wheel walker, then we progress to a four-wheel walker, because this four-wheel walker can be used in outside, like outdoors, because the casters in the four-wheel walker are bigger and they have a seat and a basket. So if they need to rest in between, they can sit down. If they need to go for a shopping, they can go in this. But the two-wheel walker doesn't have a seat or doesn't have the caster, so it's so hard to move in gravel and curbs. So we see whether they are good with two-wheel walker, then we progress them to a four-wheel walker. So other transfers are transfers in stairs, where many people do use the rails, but some people are still not strong enough to do transfer in the stair. So the government also helps with stair lift. There are special funding for seniors or people who need stair lift. So as an OT, when I say that the client is not strong enough to do the stairs or is not safe to do a stair, then we do a lot of assessment, like we do a home assessment, and then we do a paperwork to the government saying that these are the assistive devices that are required for the client to be independent and safe. And the government look for our documentation, and then they approve the funding for it. Thank you. Any questions?
Thank you, madam, for a wonderful presentation. Anyway, students, please feel free to ask questions, not only about this topic. Maybe you can ask her experience in this related topic. You can ask about any case study, what how she used to handle. Maybe you can ask anything related to this.
Thank you, Raghuram sir.
Thank you, madam.
I do see there are 4 messages.
What, madam?
There are 4 messages. Oh, okay. So it's all about asking questions. Yeah, you can ask questions. Definitely.
So hi, ma'am. This is Yashwant, final year OT.
Hi, Yashwant. How are you?
Yeah, ma'am. Yeah, fine, ma'am. So I have a question, ma'am. So for a patient with prosthetic lower limb, do they have any specific protocol for the transfer techniques, ma'am?
Like prosthetic lower limb?
Yeah.
No, they don't have. So in Canada, they make sure that they undergo a specialized rehab where they teach transfers. Mostly, they don't recommend, like if it is a bed mobility, usually the processes is removed, usually at night, right? So they do a transfer with a pillow in between their legs so that there is no much of adduction. So that's the only precaution we tell them. Other than that, there is no special precaution for prosthetic limb. It's like they make it so advanced that the limb is almost like your own limb.
Yes, ma'am.
No weight-bearing precautions or no restrictions with that.
Okay, ma'am. And when we talk about the transfer techniques, the position of the wheelchair, the thing which we're going to transfer should be like how a wheelchair should be there when we transfer a patient from the bed to the wheelchair.
Perfect. So the wheelchair should be close to the bed on a 45, less than 45, 30 to 45 degree angle. And then you put the brakes on the wheelchair first. So you make sure that all the equipments are braked and make sure that it's angled so that when you start to lift them up, you can do the pivot and then make them sit. Some people prefer transferring, keeping the wheelchair in 90-degree angle, but we don't recommend that. We always want the transferring surface to be close to each other.
Okay, ma'am. Okay. So, and also we OT especially will be working with community-based also, community-based rehabilitation also. So where we'll be going directly to their homes. So we will not be able to have the side rails on their beds. So at that time, what we have to do now?
So M-Rail is a very easy to install rail. So here, what we get the equipment and it just goes under their mattress. So it's not a big piece of equipment where it needs a lot of like fixing. Like you don't need like even a hardware to fix it. It just goes under the mattress so they can hold on to it and stand up or use it. In India, that's a good question. You guys have to tell me how you guys are doing with without a bed rail or without anything. Even a small chair that can be kept close to the bed. So that can be used also. So OT is all about creativity. So
Yes.
you can use a very heavy like wooden chair and people can hang on to it and stand up. So it's as I told you, OT, as a OT, you will be enjoying your practice because you are every day creating something. So yeah, the M-Rail, what we use here is just a piece of like aluminum that just goes under the mattress. So it's very easy to install.
Okay. Thank you so much for your presentation, and I hope my doubts has been clear. Thank you, ma'am.
Thank you, Ashwant.
Yes, ma'am.
Hi ma'am, this is Mona, final year BOT student ma'am.
Hi, Mona.
Hi ma'am. Hope you are safe in this corona crisis. Like,
So
thank you
I'm
so
proud
much.
to say that I'm in a town where there is no COVID
Oh,
cases at all. So not even
happy,
one positive case in my town. Yeah.
oh, okay. Happy to hear ma'am. And thank you for your time ma'am. For in this time you are spending this presentation with us, and also it is really elaborative, like transfer techniques, a particular session you have elaborated, and then the oil life lift and all, it's like really interesting for us to see that. And also you mentioned in that documentation is very important in your setups, like you have assigned that primary logo is there. In that primary logo, if a patient comes under the like two people transfer, if after the two people transfer they are undergoing that, whether the patient can, is it possible for the patient to go to like stage up of one transfer, or till that independency, or will they prevail on that stage? It is depending on the condition, but can we stop or making some adaptations or modifications, will can we make some independency in that patients who are in the
100%. So I understand your question, what you are asking. That's why there was like a block where you can check off whether it's an initial assessment or a reassessment. So when you do a functional assessment, it's like an initial assessment. Like you tell what logo they are. But when you start working on their rehab, you will see a lot of changes, and then you can go to a different assistance level. So that's why like this is just a functional assessment. It can be anything. So when you can start with even like a sit stand lift, and you can go to a 2-person assist, and then to the next level as a 1-person assist, and then a standby assist or an independent. So this is the first assessment which says what you see, and then when the rehab progresses, you can see changes, and you keep changing the logo as the client gets more stronger.
Yeah, okay. And also, if a patient with postural hypotension, what will be the primary transfer for them?
So if the client is dizzy, I'm not going to move them. So I'm just going to ask them. So if it is a client with postural hypotension, I always see the blood pressure before I even do anything. So when we get a client like this, we go first check the blood pressure in lying, and then we ask them to do the sitting, and then we record the blood pressure, and then we do ask them to do some calf pumping. So like just moving their ankle up and down, because the calf muscles are called the peripheral heart of your body. So when the blood pressure is like built up, when there's no low blood pressure, the client is not feeling dizzy, then you try to like do the next step. So if they are not predictable, if they are not alert, if they are not cooperative, then I won't proceed to the next step. I will be going to the safest transfer method, which could be like a two-person assist or a total assist. So I won't do it all by myself.
Okay, yes, ma'am. Okay, thank you, ma'am.
Welcome, Mona.
Madam, there is one question. Maybe you can see that in the chat.
Yeah. So
Please.
that is Shalini J is asking about home evaluation. What are the barriers that you typically encounter during your OT practice? Perfect. So Shalini, thanks for asking this question. Home evaluation is a big topic. I will definitely go into that. But before that, as you asked, when we plan for a discharge, I will explain the process today, but I won't be explaining in detail because it does have a lot of members' role to play. So I need to explain that too. So when we plan a discharge for home, we contact the home care rehab services. So in Canada, the system is like you have the hospital rehab people, and then the next team is the home care rehab people. So as I told you, our goal is to send people as soon as possible from the hospital, and then they will be followed up by the home care OT, home care PT, home care SLP, home care dietitian. So the whole team exists in home care setting too. So we will actually send the client as a home pass. So we will send for a couple of hours, and then there will be a home OT available at that moment in their home, and they will see how the client performs inside their home, because the whole situation changes when they go inside their home. They might be having some stairs inside their home, they might be having pets running in the home, they might be having a problem to use their oxygen tubing in the home. So that's why we always arrange for a home pass where the home care OT will be present and see the client moving around in their home environment. And the home care OT will be the best person to evaluate the tub transfers and then evaluate stair transfers, and then they will be doing paperwork for whatever equipments they need. So this is a very simplified version of what is happening in our hospital.
Okay, thank you so
much. What are the barriers that you typically encounter during your OT practice? Perfect. So the biggest barrier, I would say, is funding. So as I told you, the healthcare is covered totally by the government. So you don't pay anything from the pocket. So as a professional, you have a big role to play because you need to advocate for your clients. You need to do a lot of paperwork. You need to do a lot of documentation of your assessments. You need to see whether they are eligible for free equipments or whether they have to like share some cost. So that's how our role like widens up. We need to really advocate for the client, and it can take a longer time. So the timing for getting the funding can be a barrier, and very rarely acceptance of equipment. So in our country, if you tell a person, an old person, to use a cane or a walker, they will say, it's okay, I can manage. So they have a social stigma when they use a walker or a cane. To say, like, even my grandmother, like till their death, they didn't use any assistive device. Even though they walked with the treadle and bug gait. So they always tend to avoid any equipments in our country. But here they are very used to it because they see everyone uses. All the 75-year-old uses like a walker. So they are like, it's like a new car to them. We always say, oh, you got a new car for yourself, and they enjoy it. So that social stigma could be a barrier at times.
Okay, madam. Thank you.